Thanks. So for those of you who have not seen the report or read the report, first you have the highlights in your folder, and you can also find the full report online, a pre-publication version of that. So please do read. So I'm going to now introduce our next speaker, who will lead us into an exciting, hopefully, networking and lunchtime discussion that will go for about 45 minutes. So we're going to try to preserve that. So I'm going to introduce Tom Mason. He's the Acting Director in the Office of Clinical Quality and Safety and the Chief Medical Officer in the Office of the National Coordinator for Health Information Technology. And Tom has a very interesting professional story, and I've asked him to tell that story, so we'll see.
Great, thanks.
Okay, great.
First of all, I want to thank you all for having me here today. I'm really honored to speak to this group about the work that we're doing. Thank you. And as Kimber mentioned, I was asked to talk a little bit about my work as a primary care physician working on the front lines to address healthcare disparities, as well as discuss a little bit about our HHS agency, the Office of the National Coordinator, and our role in moving towards incorporating social determinants of health into the electronic health record. So back in the late 90s, I was working as a young physician on the south side of Chicago, and we were looking at the data, and there's a tremendous disparity in life expectancy for men on the south side of Chicago, as well as many men dying from preventable conditions. So at that time, we did focus groups and asked the men in the community of diverse groups of men what were the things keeping them away from the healthcare setting, and what were the things that they would want to see in a healthcare center that would bring them in. We created a program that focused on addressing the social determinants of health and created a holistic, multidisciplinary approach to addressing the health concerns of men. At the center was the patient or the individual, but with a strong component of the program was social workers. And so the physicians were working side by side with social workers with a foundation using the social cognitive theory of what were the concerns, what social determinants could we address to work towards improving the health of the community. Also central to the program was the incorporation of barbers and barbershops. So we actually had a barber within the health center at the same time the clinic was operating, that we were providing free haircuts to men, that at that time we were also having social workers leading discussion groups around issues that were going on in the community. And our barber was also a health educator and was really the center point of the clinic in developing trust with men of the community that had not traditionally been into a health center. Many of the things that we learned from the focus groups were that men felt that our health centers were designed for women and that they weren't welcomed as they saw other women being welcomed into the clinic. So we redesigned the entire health center to have more pictures, posters, and worked with the clinic staff to change the culture, to be more welcoming to men coming in, that there wasn't this perception that they were coming in for STD treatment or other general health related concerns, that we didn't wear our white coats, our lab coats as physicians, that they told us that they felt that that was a barrier to communicating and being on the same level, that there was social workers helping men with interview skills, educating men on helping with resume writing. It was a variety of social services that we provided support to the men. And one of the key components of the program was that everyone in the staff was equal, that the physician, the social worker, the barber, the front desk, the nurses, that we created that culture where the true multidisciplinary care team approach, where we all had a role to play in improving the health of that individual as well as the community. So this program is called Project Brotherhood. I was the co-medical director for some time before coming to DC and joining HHS, where we provide holistic, comprehensive medical services as well as social services to men. One other point I'd like to mention related to the program is that we had a grant with the American Cancer Society where we actually went into the community and train barbers to help to educate their men and dispel myths. I know there was a comment earlier about myths or facts that may not be true. So we really armed the barbers. We developed a culturally specific and tailored curriculum for the barbers to help educate their clientele about colorectal cancer prevention, prostate cancer prevention, that they were really our ambassadors, and we had a close connection with the barbers where we would go out and visit them every week. And as part of the program, we were actually screening men for colorectal cancer that their barbers would provide at the time fecal occult blood testing kits. And if their clients didn't have a primary care doctor, they could bring those to our clinic and have me or one of our other physicians become their primary care, or there was a program where they could also connect that information with their primary. That there were 8 barbershops in Chicago that were part of the program. We trained 2 barbers per shop, and we had 2 4-hour training sessions. It was important to us to really meet the men where they were in the community, really identifying trusted sources and helping dispel the myths that may be going around in the barbershop. But it was really a ground level intervention to really look at how social determinants are impacting the health of men in the community. And I can talk a little bit more about that during lunch, but I also wanted to move into a discussion of the importance of, let me just talk a little bit about our agency. So I'm the Chief Medical Officer of the Office of the National Coordinator for Health Information Technology. And many people may not know that our agency was actually created in 2004 by then President Bush. And during his State of the Union address, he said that every American by the year 2014 should have an electronic health record. And that year, by executive order, he created the position of the National Coordinator for Health Information Technology. And in 2009, we were legislatively mandated through the HITECH Act, which was a part of the Recovery Act, that our mission is to improve the health and well-being of individuals and communities through the use of technology, as well as information that's available where and when it's needed. That through our office, one of our key authorities is our Health IT certification program. And I just wanted to talk a little bit about the historic context of the program and us recognizing the importance of capturing in a structured way data relative to the social determinants of health. That in 2014, I want to thank the IOM and the National Academy of Medicine for the report and for convening this committee to generate a report giving recommendations on capturing social and behavioral domains and measures in electronic health records. That at the time of this report's creation in 2014, we were in the process of looking at measures and ways to incorporate social, behavioral, and psychological data in a structured way into the electronic health record. So this is a snapshot of the core domains and measures with suggested frequency of assessment from the report. And again, I want to thank the IOM that we, based on this report and feedback from other stakeholders, that we, through our process of gathering information, we use different varieties and different mechanisms of gathering feedback, that this report was very timely in terms of making these recommendations for our program. So in just 2 minutes, I'll just briefly describe how we were able to go from recommendations, getting feedback from the public, to where we are now with electronic health records and being able to capture data in a structured format. So our office, one of our key authorities is our Health IT certification program, where we provide certification and regulation of health IT modules such as electronic health records. And a key point here is that we help set the health IT standards, implementation specifications, and certification criteria for EHRS and health IT modules nationwide. So to translate that, you can think of a certification criteria as a capability or a specific function of an electronic health record. So for example, one of our certification criteria is the ability to electronically prescribe medications. So before 2008, that was really, that functionality was not a common part of electronic health records. And through the certification program, now pretty much that's the standard of care, being and looking at the safety features as well, really being able to eliminate illegible prescriptions through using electronic prescribing of medications. The drug-drug interaction checking capabilities or functionalities, those are also examples of our certification criteria. The ability to view, download, or transmit electronically for a patient health information is one of our criteria. So these criteria are put together in a set of what we call our additions of certification criteria. So there's been 3 editions, 2011, 2014, and 2015. So we're currently on the 2015 edition, which came out in October of 2015. This is a screenshot of the Federal Register, where you can also find more information about our certification program. But most importantly, for this discussion, at the time, we were looking at what are the most useful, most ready measures around psychosocial measures that could be captured in a structured way. And so based on the report, based on feedback, I'm very happy to say that this has been incorporated into our most recent edition, that for the practicing clinicians here, you can expect these measures and the 2015 edition to start being available for use in EHRs near the end of the year and going into 2018. So also a part of our program is that we help to establish through our certification program, many of you have heard of Certified EHR Technology, or CERT, that these specific measures here are a part of our general certification program, and I just wanted to make sure that I communicated that this will soon be, once physicians and clinicians upgrade to the most recent version of our program's certification criteria, the ability to capture financial resource strain, education, stress, depression, physical activity, alcohol use, social connection and isolation, and exposure to violence. And more detail on these you can find through the link I can provide through the Federal Register. But just wanted to, again, thank you, Kimber, for the opportunity to provide an update from our agency. I will be around during lunch as well, so if anyone has any specific questions or would like to follow up on any particular area, I'm very happy to oblige. Thank you.
Okay, great. So we just got a good dose of technology in IT, which I think hasn't come up in our discussions thus far. So I think that was very helpful. So it's now lunchtime. We have about 40 minutes or so for lunch. What we're going to be doing during this lunchtime session is Raj. If you'll stand up, Raj is our Archer Fellow from University of Texas at Dallas. And he will be going, yes. And he's been helping us prepare for this meeting all along the way, and he's actually going to be approaching people during lunchtime and taking them to room 104 for our fabulous duo communications team, Kara, who's in the back, and Laura, who's right there. And they'll be doing these very short 30 to 60 second reaction videos. So they have a consent form for release. They'll be recording you, and then we'll be posting these on our web. So if you haven't had an opportunity to say something or you want to make a point, definitely find Raj. He's going to be bringing people to room 104, or just go to room 104. It's right around the corner. So please participate in that. And thank you and enjoy lunch.